Dr. Honoré, thank you for joining us on MD Newsline. Can you please introduce yourself to our audience?
Awesome. I'm Collette Honoré. I'm a dermatologist who owns her own practice on Hyde Park Dermatology in Southside of Chicago.
So, we're going to be talking about psoriasis today, and I just want to dive right in and just ask you when it comes to diagnosis, when a patient presents with chronic scaly plaques, what are the specific bedside features that push you towards psoriasis versus atopic dermatitis, for instance, seborrheic dermatitis, tinea, anything else like that?
It's anatomical location and clinical presentation. So most people look and go, the textbook goes red, scaly plaques, that's psoriasis, but it doesn't present that way in everybody. It depends on your skin type, color, and melanin. So if there's symmetrical, elbows, knees, trunk, usually steer towards psoriasis. If it's on the antecubital, which is in front of the elbows, or the popliteal fossa behind the knees, along the eyelids, you think about atopic derm. Seborrheic dermatitis, you think about flaky, greasy scales in the scalp or in the central part of the face. So you're looking anatomically.
Mhm. And when it comes to presentation and different skin types, what are some of the pitfalls or places that you think that dermatologists should pay more attention to? Let's say in diagnosing this in like African American skin, for instance.
So we don't usually present with red, scaly, silvery scale. It's not that perfect. So we'll have more purplish, brownish, grayish hues to our plaques, and then they're scaling with them. It's still going to be bilateral elbows, knees, trunks, or it can most likely be in the scalp or just in the scalp alone, genital areas. And then it's the history. How did it show up? When did it show up? So history does take a toll. Usually psoriasis presents later and not earlier in life.
Mm-hmm. Do you have a way that you systematically examine distribution in special sites, such as scalp, ears, things like that, to build or break a diagnosis of psoriasis? Does it
Yeah,
matter?
I go pull up your elbows. Is it on both sides or one side? If one side, you steer towards more eczema or contact dermatitis, whereas psoriasis, you know it's going to be symmetrical. And usually, when people don't know, you should biopsy. That's the advantage of being a dermatologist, but it's pretty much easier to see.
Mhm. What are the top diagnostic traps you see in referrals, especially facial, inverse, palmoplantar, or scalp psoriasis? And what simple habits would help clinicians stop missing these?
So we treat our hair differently. Everybody does. We don't wash our hair as often because it's drier, first and foremost, and not as greasy. So you can have somebody go, it's a little itchy and scaly, wash your hair every day with that. So at that point, the person's not even going to do the treatment. They're going to be like, well, I'll just live with it. Hair is falling out, and you're thinking it's psoriasis, but not necessarily. It could be seborrheic dermatitis. Um, I've had various patients who've come in who've been treated for years thinking they had eczema. Getting worse, arthritis starts to kick in, and those are other symptoms that come with psoriasis more so than eczema. Pitting of the nails, and then they're trying to figure out, why am I putting on all these topicals and nothing's working? And then it leaves a bad scarring on us more than anything. So you walk around, even if they do go away, you have these dark blotches all over the body. So pitfall would be, let's look at it. Is it look like psoriasis? Then it is psoriasis, not because it's in a black patient versus a white patient.
Hmm. And when it comes to things like those black blotches with things like psoriasis, what are the next steps after treatment? Let's say an ideal scenario. Is it just kind of permanent, or are there kind of treatment options for things
So it
like?
depends on early detection or early diagnosis. So when people can come in and we can see them, we can be aggressive. And you can start people with topicals depending on how much surface area is affected by that person and how long before they were underdiagnosed, undiagnosed, misdiagnosed. So if you can aggressively treat them, oh no, you can clear it up quickly and get rid of some of that scarring. But to be honest, I would say about 60% of the times I've seen people come in and they weren't treated for years. And so it becomes more after we treat them and trail them up to try to do bleaching creams, chemical peels. Laser isn't the most conducive for the African American skin all the time.
Mhm.